Okay, welcome to Level 4 Health and Social Care, Unit 403 Introduction to Policy. And we're looking at part 4 of the unit today. We're looking at some of the recent proposals and we're looking at the issues about long-term conditions, and we're also looking at the assignment. So the objectives that we're addressing, we're going to be looking at 1.3 from task 1. Discuss recent proposals in healthcare policy and its potential impact on service users. And we're also going to look at 3.2 in task 3, explain the government's policy on supporting service users with long-term conditions and its implication for service users. Okay, thinking about the first part of this section, we're going to look at the Health and Social Care Act as a recent proposal. And that was introduced, and they've been working on that for the last couple of years. And it finally received royal assent to go through on April 2022. So it is a very recent proposal. And at the heart of this proposal is the formalisation of integrated care systems. And that's a system that brings providers and commissioners within a geographical area together with the local authorities and the NHS services to collectively plan health and social care services to really meet the needs of the local population. So the idea is bringing everybody together so that there is a sort of consistent vision, and so that the community services and the hospital services are and the services provided by local authorities, social services, which includes the care home providers, various community day services, those sorts of things, would all be really under the auspices of one group, one integrated care system. The decisions and the leadership on that would be an integrated care board, again with members of all the different factions on it, and they would be involved with sort of putting the vision together for your locality. So if you live in the north of England, say, or if you lived in Cornwall down the furthest southwest, you might have different needs in the area. You know, Cornwall might have a lot more older people living there, so you might need a lot more long-term care services. If you're in a place in the north that's quite industrial, you might need to do with, you know, you might need to be looking at more cancer services or skeletal muscular disorder services. So the idea is to enable the commissioners to really react to what's happening and focus on their region, really. So as I said, they'll be led by integrated care boards who would be doing all the commissioning, the oversight and the performance management together. And so as a change from, say, the CCGs, which we've talked about before, this is actually bringing a range of partners onto the board, really, and it's not just the NHS. So the NHS doesn't stand alone, with social care standing separately. The board and the staff of the care, you know, it will be a mixture, really, working together. So one of the key promises of this idea is to integrate care and improve the health of the whole population. And to enable that, the region can actually be sort of broken up into small geographic areas as well, with specific teams working in those areas, or they're frequently calling them neighbourhoods, really. And that can give local levels, so often, you know, with GPs and with with the community staff that work in that area, they're allowed to have a bit more flexibility in how they set things up. So as I said, what works in the north might not work in the south. If you work in a rural area, where lots and lots of farmland. It's not as easy to provide the community services as it is in the work on the outskirts of a city, where people can access things with bus services. So those who work in rural areas may find a sort of slightly more flexible way of doing it. They may operate from community facilities. They might even operate from the local pubs or the shops where people can come in to see them, you know, or they might do some other things or work from church halls, community centres, rather than GP's practices. So they would have that flexibility to reflect what they do. You might find community nurses in rural areas might do more visits because, you know, they're visiting farmers on farmland and they're so far away from each other. Or again, cities would have more clinics and things like that. So that would just give them that chance on a small locality. As long as it all feeds into the integrated care board and everyone is getting sort of reasonably similar access. It also merged, the idea of the Act was to merge NHS England and NHS Improvement, and to make sure that NHS England is also responsible for sort of producing the main leadership of the NHS, and the fact that they can do the improvement services as well. Well, that improvement used to be done by a standalone organisation. Again, that's been merged under their auspices. And the Act has also introduced particular targeted changes to public health. For some things that are actually coming out under the Act, they're not coming out as an advisory anymore, but they're starting to use legislation to make them happen, such as restricting the advertisement of junk foods. I've put a link there for you. It will be on your extra reading link, so you can read up a little bit more about these, about what they did. So anything that's in pink, you know that you can, I'll provide you with a link so you can read up a bit more about them. Advertisement of junk food is about restricting advertising things like McDonald's and that to after a certain time of night where young children don't see it, and certain sweeties and things like that, and crisps. So there's more issues about bringing things into legislation so they control it. There's been a lot of work on Sugar Act as well, which is about legislation about penalising companies for having too much sugar in there, and giving them very clear guidelines about sort of minimum amounts of sugar and that. So companies can be fined for certain amounts of sugar, but that hasn't quite gone through. There's been a lot of toing and froing on that one. Obviously, some of the food manufacturers aren't too happy about it, especially Cadbury's and the other sweetie manufacturers who are scratching their heads a bit to say, you know, how can I reduce sugar from a bar of chocolate without it tasting horrible? So that's, you know, that's still going on. So that never got pushed through, but it's on the back burner. But believe me, it will probably come back again. Another area is the Health Services Safety Investigations Board, which will report again to Public Health England, and they will be an independent group who will be looking at issues that have happened, you know, in hospitals, GP surgeries that need investigating. So where complaints have been brought up by members of the general public, say to hospital treatment, they've actually created an outside body. Up until then, they were investigated internally by the hospital. And unfortunately, there's been, you know, quite a lot of criticism of the quality of these internal investigations, about how things have got brushed under the carpet by the hospitals. So this external Health Services Safety Investigation Board, which would, when there's a formal complaint, will take over the investigation, has been demanded for quite a long time, to be honest. Okay. So at the late stage in the Act's passing, they added, and this is very controversial, they added an amendment to the Care Act to change the cap and floor model of social care funding. I won't go into depth explaining social care funding because it's quite complex. But again, you will have a link that you can read about it at your leisure. But one of the things I will say is up until this act was added, from about 2010, they've had the same formula for social care funding, and it was means tested. So social care funding is anything that isn't healthcare. So when people move into a care home, quite a large part of their funding is social care funding, because it's their sort of living expenses, you know, it's like feeding them, caring for them, but not doing any particular medical care. So those of you, and I know you are, who are doing your placements in social care, you know that quite a lot of it is actual just sort of day-to-day physical care. It's not something that a nurse would carry out very often. It's you know, it's sort of soft care really, and then it's the social entertainment and, you know, thinking about, you know, helping people mix, helping people with memory, those sorts of things, all considered social care. So up until now, the funding for social care is means tested. So it was identified looking at how much savings people had, you know, various things, what sort of incomes they had. So if you had less than 14,250, you would get all your care paid for. If you have more than 23,250 in your savings incomes, all added up together, you would get no support and you would have to pay all the social care costs yourself. If you got in between those two, then you would pay a part of costs, as you can imagine, in between. So in 2021, when they were putting together this Health and Social Care Act bill, one of the last things they looked at was about setting a cap on payments to £86,000. So the idea was that even if you were means tested as getting no support, the most you would ever have to pay was £86,000. And then after that, the state would sort of come in and pick that up. Now that may sound like an awful lot of money, but actually it isn't. If you sort of maybe you find out what the costs of your care homes are and sort of do some calculations, but it wouldn't take that, you know, it'd only take some people who are having quite high level care. It could, you know, it could only take 3 or 4 years to hit that sort of money. So yeah, have a look at that really. So this was an idea which was considered to be a good idea. It meant that there was only so much you could ever pay. So that was sort of accepted as part of the cost. Then at the very last minute, they added and a sort of addendum to that, which said that any costs funded by the council or the local authority after your means testing would not be counted towards that £86,000. Now, a quick glance, that sort of sounds like, ooh, goody, that's good. But actually, that's not true. So if you were someone who was going to get support, what they've done is they've actually tightened up the means test. So you have to jump through a lot more hoops before you can get that full support. I'm not quite sure now of what the amount of money that you have to have before you get the full support, but it's possible it might be lower. So what we're saying is that it's fine reaching £86,000 if you're someone who's quite wealthy, who's got lots of assets. Well, you'll pay and it's fine. And then once you get to £86,000, hooray, you'll carry on being wealthy with lots of assets, and the state is going to pay for you after that. So pretty good position to be in. If you're someone who's not really that wealthy, but maybe just tips into having to pay, you're someone who's got to find up to £86,000 before the council will pay for you. Now, for most people, most ordinary people, they don't often have £86,000 in savings that they can know they can spend over the next few years towards. So they would have to start selling their assets to make sure they have enough money over the next few years as they go along. So they may not have to sell their house immediately, but once their savings are run out, they might have to sell their house because they will have to pay at least up to £86,000. So it's very confusing, but it is considered to be unfair. It means that wealthy people, what they're saying is they think they've made it fair by saying everyone pays the maximum the same. But obviously, if I'm a millionaire, £86,000 is nothing to me. So I just go, okay, fine. But if I'm not, and if I'm living on £15,000 a week, if I've still got my partner living in the home, where do we get that sort of money from? And the original promise made by Boris Johnson was that no one would have to sell their house to pay for their care. And these changes were supposed to enable that, although it wasn't thought through that carefully. And when they put this in at the last minute, it's a bit disingenuous because they sort of carried on saying the same thing, but a lot of people who are opposed to it are actually saying, well, to get £86,000, no one's going to give an elderly person a loan, especially if they're retired. And if their pension can't cover it and their savings can't cover it, well, they're going to probably have to sell their house or part mortgage it or something anyway, which makes it very precarious for them wanting to give it to their children to inherit, or the other partner living in it. They would be money lost at the end of it. So as you can see, that's still an issue. So have a think about that, but do have a read of it because it's interesting. Okay, so looking at that, some people have said bringing in the ICSs, is it an unnecessary top-down reorganisation? Reorganising the NHS, always causes traumas. Taking away the clinical commissioning groups who've been around since 2013, was that disruptive? Not sure really. It's not been that long. So we don't know. There's been some problems about legislation which promoted competition. As you know, if in our last one we've talked about, they've had this sort of internal market idea. So it was almost impossible to do any form of decent integration so that things were working smoothly from hospital to community. Instead of working together, they've had to work against each other. So what it has done is it's removing that legislation, that competition legislation, saying that people can now work together. And they're hoping that this will be a much more productive idea. So is it unnecessary? Probably not, no, because there was no other way that they were ever going to work together without changes of legislation, really. Will they have more freedom to respond to the needs of the local population? Well, yes, they should, really, because you're not going to get a standard approach dictated sort of by the ministry saying that everybody needs to have this, everybody needs to have that. It should be, well, we get this in our area because we have a need for it, but we don't do that because there isn't much of a need for it. So you could say it's sort of more focused and targeted. Is it an equalities issue? Possibly, because if you're one person who has that need and they haven't developed a resource for it because the need is very low in your area, and then in a region 100 miles away where the need is high, everybody gets it, and there's really good services, that has to be teased out, I think. So we don't really know how that's going to work. Would it lead to greater involvement of the private sector? There is a concern of that. The general idea is it won't lead to any more involvement, the private sector than the present competition internal market idea did. Basically, there was a concern about, will the private sector, if they're very, if they've got a big presence in an area, will they be able to hold seats on the integrated care board? And what they've done to be conscious of this is that they've made a sort of tweak in the Act to say that, they have to investigate any issues of conflict of interest. So if they think that bringing a member of the private, say like a drug company or a care company, a specialist care company in, if they think that could be a conflict of interest in any discussion, then they'd either be omitted from those discussions, or they would have processes in place. So that has to be completely clear and transparent so that people will be able to challenge that. The ICS idea does actively encourage a diversity of providers. So they encourage lots of other people with specialist expertise to be working, but whether it changes that, I don't know. Does the Act give ministers more power? We started off some time ago where ministers had substantial power. When you look back to the Labour policies, ministers sort of reduced their power and made it more local. But as part of this, yes, the Secretary of State has been given a general power to direct NHS England to make sure that they're on, covering the national objectives as well, and the annual list of priorities that the Department of Health and Social Care has. So in that sense, yes, although they can do things, they will still be held accountable to national priorities, because otherwise the worry is that people could go too much their own way, and the big central priorities like cancer treatment and that they could ignore, and that's really important that they don't do that. So in that sense, the Secretary of State will retain their general power, and they will have the power to intervene in some of the decision making if the idea is if they feel that people are wandering away from the objectives, or if they feel that it's not being carried out correctly. I mean, some people would be quite worried about ministers getting involved in local service changes, because it tends to delay decisions, because it's quite a long process when you bring in the Secretary of State. So a lot of people would fight against that. So the idea is they can only get really involved in very high level operational decisions that are really, if they think they're really going wrong, but there's quite a clear sort of boundary to them. Will it make any difference to patients? We've identified that a lot of the issues for a lot of patients is their complex conditions and people suffering from long-term conditions, rather than acute issues where you have appendicitis, go in, get your appendix out and come out again. Those sort of things tend to work smoothly. It's the people with long-term illnesses that are maybe probably not getting the best deal at the moment. And the one thing that they've identified, which we will go on to talk about a little bit later on, is that they need to be worked with on a more person-centred way rather than, an illness-centred way. The NHS was very much set up focusing on the episodic management, as I said, like you go in, have your appendix out, and then you get shipped out, and the next person comes in, has their tonsils out and gets shipped out, blah, blah, blah. And so because of that, they've always been fairly autonomous. So that's the way the whole post was set up, and it's taken quite a long time to break that down, really, and to sort of realise that some people you will be working with for many years because of their chronic illnesses like diabetes, epilepsy, cancer treatments, motor neuron diseases, multiple sclerosis, dementia. Those sorts of things are not things that are incidental. So the general idea is it should make a difference, because services will be more joined up. So, someone with one of the issues for people with long-term problems is like, who do I go to? Who's looking after my care? And doctors said, oh, well, you need to see the consultant about this, and then you need to see the nutritionist about that, and then you need to see the physio about that, and it's all sort of becomes very disjointed. So there is a hope that the Act will actually bring these things together. Does it tackle some of the big challenges, such as inequalities? The idea is, because people can work locally, you should be able to pick up local inequalities, and then bring in the different types of service. So yes, in that sense, there's also a strengthening of the duty to tackle health equalities, because that's written into the Act in a way. But nationally, it's hard, because they'll be doing something, say, as I said, in Cornwall, and they'll be doing something to meet the requirements in Liverpool. Their interventions may not be the same. Some of them may tackle inequalities better than others, and that's just the way it is. So what we don't know yet is whether inequalities will add up at the end as being well tackled, or well tackled in some places and not in others, or partially tackled overall. So the jury's still a bit out on that. So we'll have to watch for reviews. I've given you a little reference then on some key questions, and as I said, there will be quite a lot of links in extra reading for you to have a look at. Now we're going to look at long-term conditions. I sort of referred to them a little bit, and we're staying on recent proposals as well over the last couple of years, really. Okay. So here's a little quote from the Coalition for Collaborative Care. It reflects on what I said a little bit earlier. People with long-term conditions overall tend to be the biggest users of NHS services, and the largest part of the health service budget is spent on supporting them. And the care and support needed is often different to that for acute health conditions. As I said, if someone has appendicitis, they go to their GP diagnoses it, writes a referral, sends you off to a clinic. If it's really serious, you go into hospital straight away. If it's not, you might go to a clinic, consultant has a look at it and says, yes, I might treat you with medication, or I might do this, or we might have surgery. You go in for surgery, you are treated, supported in hospital, little bit of discharge, out you come, might have to see your GP again, or they send a letter to the GP, and that is the end of your intervention, really. Now, with people with long-term conditions, we know it's a lot more than that. It's about, ongoing medication management. It could be ongoing physiotherapy, ongoing clinics, breathing clinics, ongoing cancer treatments, which could, spread over a year or much longer than that. All sorts of things, really, with all sorts of different types of interventions. So yes, it is different, and it is different from the way the NHS was set up. And we know that we have to find a way to help people manage their own healthcare for a large part of the time, because a long-term health condition very often doesn't require inpatient treatment. It often requires you to be at home, but to do certain things. So you might end up requiring family carers to help out more often than not. So as I said, it is a significant part of the health and social care system. At present, there are over 15 million people living with a long-term condition in England alone. That's not including Scotland, Ireland and Wales. I just didn't have those statistics. That includes things like mental health conditions, physical condition, arthritis, asthma, COPD, depression, dementia, diabetes, as I've said. These are conditions to be a long-term condition, it's a condition that can't be cured at present, but can be managed or improved, and again through person-centered approaches. And the support might be about learning new skills, changing your behavior or your diet or your life skills really. Accessing other types of community support like day centres for memory clinics if you've got dementia, as well as maybe lots of ongoing medication which needs to be managed and monitored. And sort of traditional treatment or therapies, or even untraditional treatment, such as massage, yoga therapy, those sorts of things have proved very useful for people with all sorts of different illnesses. Acupuncture is now being prescribed as a way of helping people with complex pain management. Number of people with one long-term conditions is relatively stable and over the next 10 years. However, those with multiple long-term conditions, so that's more than one different condition, are set to rise to 2.9 million in 2018. I don't know what I did there. It's up from 1.9 million in 2008. So in 10 years, it was rising by over 1 million. So if you keep that statistic, so you could say that by 2028 it would have gone up another million, and then another million. So every 10 years. So that's worth thinking about really. Consultations with people with long-term conditions takes up more than 50% of GP appointments. 64% of all outpatients appointments are long-term conditions, and over 70% of inpatient bed days, although very often there's it's because of a flare-up, maybe the condition hasn't been managed well and something like that's happened, or a diabetic coma, or a diabetic relapse, those sorts of things. £7 from every £10 of health and social care spend is targeted towards this 30% of the population. So think of that. Every £10 spent on health and social care, £7 of it is spent on long-term conditions, and the other 3 is on all the other acute conditions. The average person with a long-term condition in the UK spends no more than 3 or 4 days a year with a health professional. So basically only just going in for a 20-minute appointment at a clinic. The rest of the time, people take responsibility for managing their care, usually relying on friends and family as unpaid carers. So we looked at introducing personalised care and support. Now this, for those of you who work in care homes, this is not really unusual. This is your person-centred care that you are already fully aware of. You've already studied it and you're probably carrying it out in your placements. But it's not, the NHS has not always really made use of the person-centred approach, maybe as well as they could, because they are used to dealing with acute care, and GPs aren't always part of that. So this is really about bringing in that classic person-centred care and support planning into all aspects of healthcare, really, not just social care, where it's already quite well lodged in, as I said, in care homes and day services. There's evidence that personalised care and support definitely leads to improved outcome. There was a program called the Year of Care, which was a research program which you can look into if you want. And they developed and tested several models of personalised care planning, which proved very effective and satisfied both the patients, the clinicians, and the commissioners. There was a Cochrane review, which again you can look at, found that personalised care planning plus the appropriate follow-up led to definite improvements in physical, psychological, and the subjective health status, and definitely improved people's capability to self-manage as well, because they developed the confidence of being part of their their personal care plan. And they also knew who they could contact because it was so well worked out. They knew how they could contact when they needed help, so they would only, ask for help when they needed it. The study showed that effects were greater when it included preparation, record sharing, care coordination, and review. And the review part, as we know, is really, really important. Some of the benefits of the personalised care is people understanding their conditions and disability better. So, a lot more time is spent on talking about what your disability is, because we all have different levels of it. So instead of just talking generically, when we're doing personalised care, we're talking about what does it mean for you as an individual. People feeling more confident and being able to manage their own health care. And playing a more active role in managing it as well. Personalised care and support enable people to prevent a deterioration because they knew what to do, and they'd already maybe put some plans in place about what to do if things weren't going quite right, so they were able to nip things in the bud quite quickly. And the support was tailored, and the idea was about increasing confidence and skills management. The benefits to health and care providers, well, the consultations were more satisfying in the sense of that because everybody was involved, it felt, instead of just a routine, do this, do that, go away. There was much more discussion, and the practitioners felt more satisfied. They felt that they'd be doing something more constructive as well. Monitoring was improved because they'd put systems in place. Some of the monitoring was done by maybe carers and families, and then feeding back. All sorts of systems are put in place. Outcomes were better. So obviously that's job satisfaction again for the practitioners. And because people's understanding was better and they learned to manage things in different ways, they were able to reduce the use of medication. A lot of medication was used to help people manage pains and discomforts, where you didn't really look for any other answers. But with the personalised care, they used to find ways to put things in place so you could stop flare-ups happening, which would mean extra medication would be used, or B, finding different ways to manage pain and discomfort that wasn't always drug-based. Benefits to commissioners, well, you're getting better value for money, service users are more satisfied, you're meeting the health outcome targets, reducing medication wastage, because you've got a proper person-centered plan, you can measure it, and that gives them evidence. And it can have a positive impact on other national drivers like reducing admissions to hospital, improving patient satisfaction, as I said. The role for the commissioners, so we've got a good idea with person-centered planning what the role is for the in-house practitioners or the people that work with you, like community nurses, the GP and that. The role for the commissioners is to actually put the systems in place to commission appropriate person-centered services. And that means they would need to develop service specifications and work about the sort of payment methods so they could do that. So they would work something out and put a contract out, and you would get some local providers to come along. So it might be someone who provides community engagement, such as some sort of day service where people could go, and then some of the monitoring could happen there and some of the support could happen there. They need to consider what patients would benefit the most from, and by looking at people's care and support plans they could identify what they are. Thinking about what sort of tools they could use to make the care and support planning system easier, especially with people who have low levels of literacy, or don't understand things that easily. So they would need to put the right tools in place. And commission arranges support for self-management services. So how If people are self-managing a large periods of the time, how is that helped? How is that supported? Education programs, maybe some peer support networks, support groups are something that really works. So everybody with, say, asthma, if there's a local support group and they're managing it at home, if they go together and they meet sort of like every other week or something, and they just sort of share concerns or share issues, or sometimes they can resolve things together. And the commissioner's responsibility would be to promote the development of the workforce, or the different workforces, make sure they've got the skills and competencies, make sure that there's access to appropriate training and personal development, and also to put some sort of measurement tool in place that isn't too onerous, but that this information that's gathered, and because care plans are well documented, it's a lot easier to sort of measure outcomes from it. So one of the systematic approaches has been created, and that quite a lot of commissioners are adopted, is something known as the House of Care. It's part of a long-term conditions framework, which is available. You can research it. I've probably put a link for you for the House of Care, and it's known as a whole systems approach. And it's one of the sort of recommended approaches. There are others, but quite a lot of local areas are picking up on the House of Care idea. So if you want to give an example, it's one of the ones you might want to use. So this is a graph of the House of Care, and yeah, not surprisingly, it looks like a little house. That's the idea of it, with a roof, some walls, and a floor. And the idea of it is that it's a safe structure. You've got the roof on to keep you safe and dry. The carer is in the middle, living in the little house, and you've got the two walls and the floor there to keep them safe and secure, so they don't fall out, they don't get cold, they don't get lost. So if you have a look around, and I'll talk through some of the major steps. So the roof is all about your organisational and supporting processes, and it's basically identifying that you need some processes within the organisation, and this could be within your care home, or it could be within the community health services, and you can identify that you know what the process is. So the most important thing for commissioners is, does your organisational process allow you to find out what patients' preferences or service users' preferences are, so they can actually be gathered and fed in, so that they can, from you as a care provider, find out what the sort of personal preferences of your users are, and they can use that to inform their commissioning. The left hand wall is about engaging and informed individuals. So again, without that wall of people knowing and people being trained to understand about their illness, and being educated about their illness, then they can be a lot more part of the conversation. On the right hand wall, we have you, the healthcare professionals, who are working in partnership to support those service users. And to do that role, all the people on the right hand wall need to have the skills, need to have the confidence, and they need to have the training to work in a collaborative way. So you'll often be, more often than not now, be part of a multidisciplinary team. You need to work on how you deliver coordinated person-centered care. And if you worked in a care home, you'd be focusing first of all how you coordinated it within the home itself, and then secondly how you coordinated it and what sort of relationships you had with the other people who brought other support in, like the community nurses, the GP, the physiotherapist, and that, you know. And you might want to sit down and work out how you improve, what you can do to change it. But to do that, you know, people have to be trained in a way, and they have to be trained to work collaboratively. So you're going to need training and skills on supporting these long-term conditions, some actual skills on that. But you also need training and skills on working as a team working as well. So lots of work on team working, because that's really, really important. So at the foundation, the bit it's all resting on is responsive commissioning. So again, it goes back to the guys who pay, the guys who actually fund the services and what services they buy. So it's really important that they get all the right information and have the right structures in place so that they can make sure that people's needs are met. And it's not just their biomedical needs, because very very often when the NHS has, when we had the CCGs, which was really based by NHS staff, they very much focused on biomedical needs, but often didn't think a lot about social and physical, mental needs as well. Whereas you do when you work in the care home. So that information will be going to the commissioner so that they will be making sure that they can actually commission services that think about those holistic needs as well. And it could be making sure that people have advocates to speak for them. It could be starting self-help groups, you know, or giving some funding to a local organisation to start self-help group for peer support. If you've got a lot of people, as I said, with diabetes or epilepsy living in the community, or mental health problems particularly, self-help groups that might be just, you know, led by a voluntary organisation or something. Age Concern, one of the big mental health services, Mind, they often run self-help groups. The commissioner will pay them to run groups in different areas that people can join into, which will help them self-manage as well, because they will get the support. And if things are going wrong, they'll find out in their group. People might say, you know what, I think you need to talk to your community nurse, etc. Okay, so that's your house of care with your floor, your walls, and your roof. Okay, so it's quite a nice little image. So what are the drivers of these things? The NHS mandate included an expectation that people would be empowered to shape and manage their own health and care and make meaningful choices, especially those people with long-term conditions and those receiving end-of-life care. And they identified that this could be better achieved through personalised care and support planning. The Care Act focuses on well-being and prevention as well. So again, the Care Act stepped away from the simple NHS view, which is about you know, just dealing with that acute illness, sorting them out when they are in, and then sending them out. There is much more focus now on general well-being, helping people manage, and also prevention as well. Because if people are managing their self a bit better, they will have less inpatient events, which is what everybody wants, really. It also supports personal budget. The NHS mandate 2617 includes the goal that 50 to 100,000 people should have a personal budget, or an integrated personal budget. The current estimate was about 4,000, but I think it's jumped quite a lot actually in the last year or so. And personalised care and support planning has to exist to help make personal budgets work well. Now, as I said, when I was working for a local authority, before I moved on in 2011, we were using personal budgets, but it was quite difficult to get the NHS staff involved. We had to, you know, set meetings together. Sometimes they came, sometimes they didn't, because they didn't see it as a priority. They saw it as a social aspect. They weren't really always engaging their time with things that weren't health aspects. But now the Care Act is saying you absolutely have to. So it's it's becoming part of their role to do so. Here's some references for long-term conditions. Okay, so that's the end of the sort of information, the 4 parts for Unit 403. I'm just going to talk quickly through the assignment for you now. Okay, task 1. Task 1 is 900 words. There are 3 elements to task 1, 3 questions for you to address, okay? And it takes you over part 2, part 3, and part 4, okay? So the first one is summarise the main healthcare policy reforms introduced by the Labour government. So you just need to give me a summary, pick out some of the main ones, what you think are the most important reforms, and give me a summary of them, okay? Which, each one only needs about a sentence, okay? And 1.2 is pretty much the same, but you're focusing on the coalition stuff that we did in part 3, okay? And that's the Conservative Liberal coalition. So again, pick out some of the main changes or the main issues in the coalition government's health agenda, and just summarize them, again about a sentence really. Within that sentence you need to find a way to show me that you understand them, okay? And I'd like to see references answering each question, okay? So don't forget your citations in each one of these. So because they are government policy, you have to have a citation for them, okay? So 1.3 is really focusing on what we've done today, part 4, okay? So discuss recent proposals in healthcare policy. So out of that, you can pick out really about integrated care. You can pick out sort of maybe changes in funding, changes in costs. You don't really need to do too much on that, but and just a discussion about them. So a little bit of explanation about what it is, okay? But the main part is it's asking you for the potential impact on service users. So only pick out a recent proposal that you think you can answer about an impact on service users, which is why I would suggest you look at the integrated care system, because we've highlighted possible impact. Now, we know the recent proposals haven't been reviewed, so you can't say it's a definite impact. Just make sure you're clear on that. You could say it's a potential impact. You can see I've highlighted potential impact. So, what impact are they hoping to have? And just say, this will be confirmed when reviewed in future. Okay, we'll be clear on that. Okay, let's look at, remember, 900 words for task 1. You can probably split them up into 300, 300, 300. That will probably work for this one. Okay, let's have a look at task 2. Task 2 is 600 words. You have 2 questions. You might want to shift the balance really a little bit on this one though. So 2.1, with reference to task 1, discuss the ideological background. So I don't want, we've talked about 2 ideological backgrounds. This is all in your part 1 set of slides. So go back to part 1. We've talked about 2 ideological backgrounds. I want you to highlight which of, Labour, Coalition, Tory, which one meets which ideological background. So, when you're talking about the ideological background, say, give me an example from task 1 from some of the policies. So you don't need to explain the policy too much. So you could say, see Labour's policy on, I don't know, not integrated care, Labour's policy on funding or something like that. Just have a look at it really. but relate it to that, or the Conservatives' policy on long-term care. Because remember, we've got the Labour Party first, the coalition, which is Conservative and Liberal, and that's a bit confusing because they're a bit of a mix of the two ideological backgrounds. Okay, the Tory party is very clearly one ideological background, and the Liberals are a bit more like Labour. So what you see is the coalition group are a mixture of the two, and then the recent proposals who are underneath the Tory party on their own, they are very much the other one. So I'm not going to tell you which one is which, because I want you to go back and work that one out for yourself. Okay, so you might want to write a little bit more on 2.1 than on 2.2. You might do 400 words, 200 words. 2.2 is how stakeholders can influence policy development. Don't write everything about stakeholders. Just pick up a little bit on like who they are and why that can influence policy developments. Okay, and you could probably do that within 200, leaving yourself 400 for task 2. Final task is task 3. It's 500 words. You can probably split this one in half. And we're looking at 3.1, discuss a policy developed during the coalition government and its impact on service users. It says very clearly discuss a policy, so you only have to pick one. So go back to the lecture and slides for part 3, coalition government, and just choose one policy that's mentioned there that you think you can explain an impact it might have on service users. Now, you might have something that's already been reviewed and you can identify the impact. That's fine, say so. Or you might have something that you think, well, they're planning to have an impact. So, and you could say, if you can't find any research, say this hasn't been reviewed yet. Okay, just be clear. If you do find the research, obviously you'll get marked for that as well. 3.2 is explain the government's policy on supporting service users with long-term conditions and its implications for service users. So it's really everything we've talked about today. Yeah, and you might just want to pick out an element of the policy on supporting service users with long-term conditions and its implications for service users. So you can just pick out one element of the things that we've said and why that can have a positive. So maybe integrated care, really, person-centered care. If I would focus on that and why and what sort of implications that might have. You could say this is a brand new policy. It's only come into force in April 22. It hasn't been reviewed yet, but you can just say what they plan, what they hope, you know, what outcomes they're hoping for, really. Okay, so that's all 3 tasks. So good luck with that. If you do have any questions, you can WhatsApp me. You know where I am. Okay, I'll let you go then, and I will see you in the next unit. Okay, thanks very much.